I welcome everybody to this Friday academic, which is held every month under the activity of Indian Foot and Ankle Society. I am Dr. Kamal Dureja, President of Indian Foot and Ankle Society, and I appreciate Dr. Chris taking out time for this Friday academics, and we are expert panelists. And we have today 3 young budding foot and ankle surgeons who will present their topic. I request them to stick to the time, and post the presentation, we'll have a discussion, and then we move on to the second speaker and then the third speaker. And then at the end, again, we'll leave some scope of discussion. We are also expecting Dr. Vinod Panpavi to join.
He has joined. He has joined.
He's great. Welcome, Dr. Vinod Panpavi. With your permission,
Professor Vinod, you're muted.
Yes, my apologies for joining a little late here today because I had issues with my fellow, and then he had to be pulled out some other case. So I may have to leave a little early, but I'll try to be with the meeting as much as I can. Again, thank you for putting this show, and we're really obliged to IFAS to give us this opportunity to discuss and learn from these interactions. Again, I want to thank Dr. Krish Boots from Europe. He's a leader there and well-known international figure for the European Foot and Ankle Society and worldwide. I've had a privilege to see him, work with him on a conference in Brazil. Obviously, internationally renowned folks are with us today. Kamal Dureja, our president, and our Rajesh Shaiman. Really looking forward to interaction, and without delaying further, we can get started if you all want to go ahead, and we can start with the first case.
Yeah. Thank you, Vinod, for your kind words. And here we start with Jagdish Sakya doing his presentation. Kindly.
Should I, sir, share my screen?
Yeah, share your screen, please.
Sir, could we, another presenter will present first, and I will present the next case.
Yeah, we can do that. Aradhana, are you ready?
Aradhana, can you share your screen?
Yes.
Sir, is my screen visible?
I was going to say.
Yes, it is visible.
Okay. Can I start, sir?
Yes, please start.
Yeah. Good evening to one and all. I will be presenting the case of a translational osteotomy. This was one of the difficult case and well-planned case in my foot and ankle series managed with Elizaro. So if we go to the history and examination, the 24-year-old male patient came with open heel injury in the past, and there was a history of calcaneus resection and heel pad completely lost, and skin grafting was done. And if we can see the picture here, we can see the skin grafting being done, and that is the end-on view of inferior aspect of the talus visible. So clinically, there was no dorsalis pedis or posterior tibial artery, and we got the angiogram done. It also confirmed the same. The foot probably was alive only on collaterals. Sensation of the great toe and second toe was present, but other 3 toes were reduced. So clinically, we can see equinus and foot valgus, no heel pad. Now, we had a lot of problems to salvage this foot, which was explained to the patient, but the patient was very much keen in having his foot with him and requested to salvage. So I went ahead for planning, got his x-rays done. He was, in fact, hopping when he came into the clinic to us. So x-ray shows absence of calcaneum, midfoot completely disorganized, and there was a K-wire in situ, and we can see the heel pad shadow not to be seen. Midfoot and forefoot sole is seen, the shadow is seen. So this was my plan.
Aradhana,
Yes, sir.
Okay.
Yes, sir. Yes,
Let's stop, because we're
yeah.
giving away everything. So can you go
Yeah.
back to the previous slide?
Okay.
Go
Yes,
back to the
sir.
previous slide.
Yeah.
So
Yeah.
let's have some discussion here, I would say.
Yes, sir.
Obviously
Yeah.
there are many ways to manage this, and we have talented speakers and leaders in our group here, and let's get some opinions
Yes, sir.
out there. Let me see if Dr. Chris Birds, do you want to comment? Do you want any more information on this case, or?
Well, can I be quite blunt? If the patient is having a loss of sensation and only collaterals, I think you will put a lot of effort in trying to solve this fit. I mean, I think for me, it could be an indication for an amputation. It's probably the best thing that you can offer to this patient. But I can understand the psychological burden that the patient doesn't want an amputation, but he's not using his foot. He's hopping all the time. So what makes the difference?
That's true.
Yeah.
Any other opinions we have?
I think I would totally agree with Professor Chris about this, but at the same time, being an Indian in an Indian psychology, there is a lot of sentiments, not from the patient, from the family members, about amputation. And they would go all over the world to get the limb salvaged. The moment you say amputation, it is a disaster for them, both emotionally, in themselves, and financially. So that is a common problem we all in India have. So yes, definitely the first choice would be an amputation, but yes, we should always think about salvage in the Indian scenario because of the sentiments, if possible.
How would you, so if you have to salvage this, how would you do that?
A very difficult thing, because there's no calcaneum here. And the forefoot is completely in equinus, compensating that calcaneal deficit. So, but then we need to have a plantigrade feet. So, yes, probably Aradhana has done an 𝐒𝐴𝐿𝐴𝑍𝑟𝑎𝑣, but probably in my hands, I would probably think about an osteotomy. But I would like to have a CT before I comment on what type of osteotomy to be done.
Can I ask, was there you're talking about the vessels, but was there a good angiogram done, an RCT scan, or?
Yes.
An
Yes,
RCT scan was
yes,
done?
sir.
Yeah,
okay. CT angiograph was done, sir. I couldn't retrieve the images of the CT angio, but I just got the reports of the CT angio.
So couldn't balloon
and it was only
or some vascular work could also be done. That is also something which we'll have to think about when we think about salvage.
Okay.
Yes.
Any other opinions?
Broadly speaking, I think because the heel pad is gone, so probably the plantar skin, which is under the head of the talus, if that could be utilized to convert into a heel pad, and that would happen if the whole of the talus is translated posteriorly. Now, whether this translation will be possible acutely or gradually with some kind of an 𝐒𝐴𝐿𝐴𝑍𝑟𝑎𝑣 system, that is something to be discussed with vascular guys, whether this kind of a patient, will it tolerate acute translation of the talus posteriorly? So this is my thought process for this case.
Mr. Chris.
But do we have enough clinical information? What's his knee like? How much is the shortening? Does he's hopping? Does he have a complete knee extension? Doesn't he have a complete knee extension? And does that change your program? Because if you don't have any complete knee extension, then you have to do something at the ankle joint as well. So it's not only, I mean, how is the clinical examination of this patient for the rest of his lower limb? Limb shortening, knee extension, knee flexion?
There was no fixed flexion deformity at the knee, sir. Complete knee extension was possible, but he was unable to keep the foot on the ground because it was difficult for him to walk on the toes. So he was not keeping it on the ground. but knee extension was complete.
And the skin, can you show the
Yeah.
picture again of the skin of the deer?
Yeah, this was from the posterior aspect, from the sole. Yeah.
So there's a skin graft.
Skin
Over the
graft
heel.
was done. Yeah, over the heel.
Okay.
And these
you.
were from the lateral view and the front view. The sensation was lost on the dorsum aspect, sir, but the plantar sensation was not completely absent, but it was reduced, but it was present.
So what he's asking, Radha, is how much was the shortening per se? So I think it's because of the shortening he was not able to put the toes down. He was not able to touch it to the ground.
Sir, it was not flexible. It was a kind of semi-rigid, I can say. The moment he keeps the toes, it was not getting dorsiflexed. That is why probably he was not putting it completely on the ground.
So the question is, there's no knee flexion contracture. Is that right?
No flexion.
So the loss of height is basically because of the loss of calcaneus, because the tibia is intact. Is that correct? So yeah, so far we have two, obviously limb salvage solutions. Dr. Simon mentioned Lizarov and Dr. Dureja mentioned osteotomy to kind of posteriorly shift the foot, I believe. Is that right? So as to get the talus or head of the talus or even the midfoot underneath the tibia, and then use the plantar sole, which is leftover sole as a weight-bearing surface. So let's see what you got to do, Dr. Aradhana, because I think.
Can I? Yes, sir. Proceed, sir.
Yes, please. So.
Yeah. I went ahead and did a paper planning, and initially for equinus correction, I thought of doing a dorsal closing wedge at the level of neck and midfoot of the talus and midfoot, but that will never help me to get the sole back. So I thought of doing a kind of oblique translation posteriorly, which can get the midfoot sole and the forefoot sole behind. So this was my plan, but I wanted to do it in stage. Initially osteotomy, and then wait for a week or so, and then proceed with the fixator. Because if gangrene has to happen, maybe probably in 4 to 5 days, I will see the changes and then proceed with my fixator. So initially I did only the osteotomy, and here the video can show the dorsal closing wedge, it is closing, but only thing is residual, the sole has to move backwards, and the valgus correction and rotational correction, which I can manage later on after putting the frame. So after a week, this was intra-op, around 2.5 centimeter of dorsal closing wedge was carried out, and this is the 6-ring construct which I have done for the patient. I will be explaining it. Shall I explain it, sir, or should we discuss it?
Yeah, I think because I think we are allocating about 20 minutes for each of the case, right?
Yeah. Okay. Yeah. Okay. So ring 1 and ring 2 can correct the residual shortening which the patient should have. So corticotomy was done between these two. Ring 3 and 4 will be a single construct, and ring 5 and 6 are again single construct. The translation should occur between ring 4 and ring 5. These are the tentative sites of ring 4 and ring 5, and that is depicted in this C-arm image. Ring 4 was put, and the ring 4 has to be oblique and parallel to the osteotomy. Ring 5 also parallel to the osteotomy. Now, if we see, this was a complete frame construct. The translation has to occur posterior and lateral as well. So the struts were put in the same direction. 4 struts were put in the direction so that the translation occurs in the posterolateral. The black color what picture represents is the inferior aspect of the talus, what we see, and this sole has to move towards that. And if we see on the right hand side, this picture, the ring 4 and 5 are at the same level. Now, if we see, this was after the correction, we can see ring 4 and 5 are at different levels now. He has completely done the translation really well, and I have corrected the residual equinus acutely in the OPD. And this was after equinus correction.
So
Yeah,
do you
and-
have a,
Yeah.
do you have a final
sir.
experience? Or?
Yes, sir. And these are the follow-up with limb length thing. And these are the final images, what we can see. It's as Kamal sir rightly said, I have translated it completely posteriorly and protected it with a cast. And these are the final x-rays, what we can see. Some olives were remaining inside, but I couldn't retrieve them. And these are comparative X-ray and my planning, which I have executed, and it is very similar to the X-ray what we can see now. These are the final X-ray images, sir.
Wow, it's amazing. You got that correction and translation. It's not easy, technically extremely challenging, and I'm sure you're glad the foot survived all that osteotomy and everything. It's great planning. How is his function now?
I can, this was, he's walking, sir, because I have overstuffed his cast. So he's put a cast shoe, and probably that has increased the length by around 2 to 3 centimeters more, but he's walking independently without any support. This is the video which he shared with me from his house.
Okay, so he's probably not lives close by to you. So is he in a cast now?
Yes.
Or?
I have removed his cast and made it bivalve kind of thing. So whenever he's planning to go out, I have asked him to use.
How long did it take for a whole treatment process?
Around 8 months.
Still under treatment.
Completely 8 months. Yeah.
Perfect.
How long was he in the frame, can I ask? It's a beautiful case. Congratulations.
Frame, probably 7 months plus 1 month I gave for consolidation to mature, sir. 7 plus 1 month, 8 months, sir.
Impressive.
Yes,
Absolutely fabulous outcome. Ratna, it's a very unique case. I think, some cases like this do have a place in, journals. I think so. I think you can certainly try a case report, because there is a JBJS case connect.
yes, sir.
You can certainly try to send it there if you have adequate follow-up.
Yes,
I would certainly encourage you to, it's a difficult problem. Obviously amputation would be much more functional these days with the processes and things like that, but you have to also respect the cultural and patient's, desires and things like that. If you can restore function which is acceptable to the patient, then yes, we have a win here.
Yes, sir.
So perfect. Any questions from the audience? Anybody else? Any comments?
How difficult Aradhana was to rotate the talus down?
Rotate, sir, or translate?
Translate.
Initially, what we did is around 2 to 3 mm of distraction we did, sir. Translation, I did not find any kind of hindrance for translation, sir. I did it only 1 mm per day, and I used to give break on Sundays or Saturdays if the patient has pain. Yes, sir. Around 5 centimeter of translation the patient had to do. He took around 2 months to complete the translation.
Perfect. Again, I want to congratulate you, Dr. Aradhana Rathod.
Thank you, sir.
Great job. Great case.
Can I ask
Can
one more
you?
question?
Sorry.
Yes, sir. Yes, sir.
If his blood vessels were better, would you consider to have done a fusion of the ankle also to give him a bit more stability?
Yeah, I thought so, sir. But probably I was focusing mainly on the equinus, and my focus completely went towards the equinus part of the foot. So my osteotomy landed up at that point, and I didn't wanted to take another osteotomy because I already did a corticotomy higher. So I didn't wanted to kind of compromise with already the arteries were feeble or not palpable.
Yeah.
So if I touch the ankle, probably I thought I might land in trouble. So I
I thought that's what I'm saying. If the arteries were better, then it could be an option. I think it's.
Yes, sir. Yes, sir.
I think
Okay.
I think the ankle would have become stiff at the end of all this procedure, and it
Yes,
would
sir.
just have probably a jog of movement. And if the patient, as long as he doesn't complain of pain, you can pull it on, and always consider it at a later day if he comes back to you with the ankle pain. But such patients who get so much of reward, maybe they are quite well tolerant to what they have got now, and he won't come back easily for another surgery.
Perfect. Shall we move on to the next case, because we
Yeah.
have, I think, about half an hour left.
Yeah.
So, but again,
These-
congratulations, Aradhana.
Thank
Thank
you,
you.
sir. Thank you, sir.
Thank you. Jagdish, are you ready? Jagdish, can you share now?
So Chinmay is here. We can ask Chinmay now to share.
Dr. Chinmaya?
Yes, sir.
Yes,
Shall I present, sir?
Yeah,
Yeah.
please
Yeah, go.
start.
yes.
Sir, is my screen visible, sir?
Yes.
Yeah, go ahead.
Yes.
Yes.
Uh, Good evening, everyone. Thank you for giving me this opportunity to present today. With me, I bring greetings from the coastal town of Karnataka. So moving ahead to the case, my sincere thanks to my mentor, Dr. Rajesh sir, for letting me present one of his case in whose management I was involved during my fellowship with sir. So coming to the case, we had a 59-year-old diabetic who had an alleged history of fall, and he had this X-ray. So, how do we proceed ahead, sir? Like considering his soft tissue, good soft tissue status, vascularity, I think we should. Everyone would agree with the span scan and plan. And like his initial management was done elsewhere, and so this was what was done for him outside. So was this ideal?
Okay, let's go back to the previous X-rays. One more. One before that. Okay. Okay, so here we have a significantly displaced. So he came just walking in the door. Is that right, or has he been?
Sir, his initially he presented elsewhere. So this is
Okay.
not like
So
this was not.
when you saw him, was he
didn't-
walking on that, or at least attempt to walk, or limping?
No, sir. He
Okay.
was not walking.
Okay, let's open up the discussions
What
here.
was the skin condition when he came to
Obviously,
you, Chinmay?
It seems to be an open fracture, though. No?
I'll share the skin condition later. Like initially, all this management was done elsewhere. So this is not when he presented to us. Like these were his X-rays in the outside hospital.
okay. So you saw him with a little pin going up in the hindfoot,
No,
right?
sir. No, sir. Much later. I'll
Oh, okay. There's still more
come
story.
to that later.
There's more story to it. Okay.
Yes, yes.
Obviously,
So
I mean,
was just
everybody wants to know. Sorry, somebody needs to speak.
Sir, I was just wondering, is it okay to pass a Steinman pin like in the initial for the temporary stabilization? Is it okay to pass a transcalcaneal pin?
Yeah, let's open up the discussion. Yeah, there are situations you can do those things, but I suppose you have more story to tell, right? I mean, obviously, people want to know what was his skin condition like. Indrajit mentioned what's A1C, how long has this been a diabetic, how many years has it been diabetic, sensation, loss of sensation all the way up to the knee or higher, what kind of his other things. Any folks have any other comments to make at this stage?
So if your question is that, is this the right plan to pass a pin? I think in today's time,
Yes.
no, a big no.
Yes.
You have a plan of, putting an X-fix, putting a transcalcaneal pin, putting a frame from tibia, proximal tibia, all the way going to calcaneum, and maybe also stabilizing your metatarsals. So you can make a triangular frame, stabilizing these kind of fractures rather than passing one Steinmann pin. This means you are potentially infecting your calcaneum, talus, and the tibia. These pins which are coming out of the skin are a potential source for infection. So a big no to this kind of management. Now you can proceed and tell us what happened next.
Yes, sir. So, so he was further evaluated with the CT outside, and I mean, it clearly shows a bimalleolar fracture with, I mean, there's no involvement of a posterior malleoli. So outside, then they went ahead with the definitive fixation. Are there any comments on this definitive fixation? Like,
It's going to fall apart. We know that. Definitely.
Yeah, he's a diabetic guy. It's not okay.
So even in this one, if they maybe added a syndesmosis fixation, we would have said at least they have done primary thing in a right manner, but transsyndesmotic fixation is missing.
yes, sir.
So the median malleolus doesn't look fixed. It's percutaneously past screws.
Yes, sir.
Yeah. This kind of,
Even
this
the
kind of
length of
patients.
fibula is not right. The fibula is not reduced properly.
No, the
There's
fibula
no
is too
reduction
short,
at all.
that's for
Yeah.
sure. Yeah.
In patients who have diabetes and, pretty neuropathic patients, I think, stability is the most important thing you should provide for this, whether it's an intramedullary nail or whether it's multiple syndesmotic screws, but we have to provide extra stability there and for a long time. Otherwise, this is going to fall apart. This is because, if the initial displacement, if you had access to the previous pictures, at the time of present, I know at the time it presents to you, you can see how displaced that was. And if the patient walks on it, has been, neglecting this or doesn't seem to be in much pain, that is a big red flag.
Yeah. Even if you, I think one of the neuropathic foot, you should go for a protibial screws, multiple protibial screws.
Absolutely. Absolutely.
Yes, sir.
Dr. Dureja mentioned that, we need to have syndesmosis, but multiple syndesmosis screws. Okay, let's proceed in interest of time.
Oh, yeah, I mean, as everyone rightly said, I mean, this did fail. And like again, he underwent debridement. And then when he was advised amputation outside, that is when he presents to us with this clinical picture. I mean, you can see a big wound on the medial aspect, and also the wounds on the lateral aspect has not healed, and the limb is clearly showing signs of reduced vascularity, and these were his x-rays. So, and his only demand was that we should
Please do not have.
yeah,
That's true.
So we had a 57-year-old male with almost all complications of diabetes. He had retinopathy. He was on regular dialysis, and he was known case of heart disease. And add to all that hypothyroidism with a BMI more than 35, and his Doppler showed a monophasic flow from popliteal, and so like when we
So what do we do now? That's the main thing, right? Chinmay,
so the road ahead was to solve our problems. Our main problems were septicemia, diabetes, and nephropathy, impaired vascularity, and neuropathy. So we did go ahead with
okay, let's stop there. Let's invite some opinions here. Anybody wants to speak about the next steps they would like to take?
If I just can comment on the primary treatment, what we should do in those patients when they come in, we'd like to solve the subtalar joint, because that's still good. So we go over for an intermedial tibia nail that we fix, bring the length, bring the length back to the fracture, and fixing the tibia in the talus. So the tibial nail is fixed in the talus and in the knee. So you have a good length with the subtalar joint. That's probably for the primary treatment. And you don't bring any bridges, and you have a good stability and a good length, and you can leave the nail in as long as you want to. So you don't need to put an external fixator on. But now, do you have any CT scan? How's the bone is looking now?
Chinmay?
Yes,
Do you have a CT? So
no,
the
sir.
question is, do you have a CT scan?
At this
And
Yes,
do we
did
need a
take
CT scan?
Yeah.
We did.
So if we need a CT scan, what information are you looking for, and how would it change the management?
Talus.
Is the question. We want to know whether the talus is alive or not, or is that it, or is it
No, the quality.
the quality of talus? Okay.
Yes, so we did take a CT, sir, on to plan, but currently I don't have the images with me.
Got it. So, any other opinions? Whether obviously there is a medial wound there, and you said the patient is septicemic also. Is that right?
Yes, sir.
Okay.
Yes,
so, his septicemia will not subside unless we do something. His probably blood sugars are high up as well.
Yeah.
A1C is that will not come down unless we do something. And then the question is, do you do a staged management, or do you do something else? What are other things we need to be doing? Yeah, I suppose we can't ask Rajesh Simon because he probably is involved, and it's probably anybody else in the audience. Is Dr. Rathod there at all, or she
Yes,
left?
sir. Yes.
Oh,
sir.
okay.
Sir, Kamal sir has raised. Yeah.
Okay, sure.
No,
Come on.
Yes, sir.
I would love you to first tell. Because
Okay. Yes, sir.
You've been
Yeah.
doing FX and all those things,
Yeah.
So
Yeah.
Tell us, what would you do?
Sir, I would consider for a debridement with the fixator application. Then plan the definitive procedure once the condition stabilizes. So fixator with debridement in the initial stage, sir. Then think of a second stage, whether internal or external. I can continue. In fact, I will think of it later.
Okay.
Yes,
Chris,
sir.
would you go for a staged approach, or would you?
Yeah, of course. The first thing to do is, if it's really septicemia, you have to get rid of the main factors. So it's multiple debridements, stability, all the basics back. Bring stability to the bone, do multiple debridements, try to multidimensionally see what he needs from antibiotics, and do a follow-up, and then stage procedure.
I agree. Obviously, the external fixator is very safe, because you're not putting anything intramedullary, and we can reduce the deformity certainly gradually as well. And antibiotics, sometimes we use antibiotic cement and things like that, but this is a superficial wound, I think, on the medial side. So once you reduce it, if there's access to the ankle joint, I don't mind putting sometimes vancomycin mixed with calcium sulfate as a local delivery of antibiotics, and certainly put a frame to come back later. But I will attempt to reduce the deformity, because if you do not reduce the deformity, the ulcer will not go away. So, and you certainly will require Achilles tendon lengthening, soft tissue releases to bring that talus back underneath, and decompress that medial soft tissues. Very important to do that.
Can you do it in one stage, you think?
No, I don't
Can you
think so.
do
I
it
mean, I will certainly not put anything intramedullary. I will certainly use an external fixator, but I will
Yeah, of
attempt.
course, but can you do the reduction, and if you're so long out and with the wounds, can you do it immediately or do it staged to bring it back under? I think
Yeah, I mean, I have done similar or even worse cases, and we are able to reduce the deformity for sure, as long as you do the soft tissue releases. Very important.
Yeah.
You would
Achilles tendon
you would put a
lengthening.
normal
And also osteotomy of the fibula sometimes, you need to do
Yes.
that to bring it down. If you don't do that, you will not reduce it. But I would like the reduction happen. That's how you decompress the medial side wound. The soft tissues are very important to be free of that internal compression or internal pressure on the wound.
would you go for a coverage temporary when you put your frame on?
No, I do not. I leave it alone.
You leave it
no,
alone.
Leave it alone.
But
Basically,
you prepare for a coverage in a later stage.
yeah, at a later, sometimes you'll be surprised that these people will heal. Amazing, the amazing potential to heal these wounds. Even up to, I've seen wounds all the way into the talus, all the way into the talonavicular joint, all the way into the ankle joint. Amazing. If you reduce the deformity, that soft tissue will heal rapidly, just like that. Within 2-3 weeks, it will heal, even without any wound vac. We see in Texas, we see a lot of big patients, a lot of fat patients. Then I was here with us, and 300 pounders, 400-pound people. and what amazes me is their healing potential, though. Is these folks, they heal.
So do you, Professor Vinod,
Sorry, Anjali, I think we like to wrap it up
Sure.
fast because
Yes, I understand.
we'll otherwise no time left for the third speaker.
I understand.
Please, Chinmaya, now go ahead.
Yes,
Chinmaya,
sir.
please.
Yes, sir. So yeah, we went. So with the help of our microbiologist, we got to get a good antibiotic regimen. Our endocrinologist helped us manage his sugars and thyroid, and he was on constant dialysis. And I think the key here was with the help of our vascular team, wherein they went in and did a balloon angiography, peripheral balloon angiography, and restored the vascularity. So and we went ahead and with debridement and went ahead to stabilize temporarily using a tense nail. So
Okay.
after, sir?
Keep going. Yeah, keep going.
Yeah, yes, sir. So after around 6 weeks, once the infection settled, we went ahead and looking at the blood parameters, we did remove the tense nail and again immobilized him with the TCC. And we waited for some time to look for any relapse of the infection. And finally, we went ahead for a hindfoot reconstruction. And this is his present clinical photos. And so 8 months after presenting to us, currently he's mobilizing in a crow boot. And I know it is too soon, but hopefully he'll be changed to a customized footwear. So,
Good job. The only thing I want to warn, folks, I've seen these kind of scenarios. These people, again, I'll go back to that comment I made. They have great healing potential. Even if it is osteomyelitis, they will heal very well. You see, and sometimes they come back with intramedullary infection. You just remove the hardware, and then they will bounce back completely. So sometimes I have also prophylactically removed once you have consolidation. Or if there's any windshield wiper effects destroying the bone, I have prophylactically removed this because I've seen scenarios wherein they get infection and somewhere else they go and then they just do amputations. So you have to watch out for that and educate our patients. But I think job well done. Is there any comments, closing comments by anybody?
Well done. The only thing that I said that we do is from the start we do a nail from the knee down, so you spare the subtalar joints. That's what we learned with our diabetic fractures. It's working quite good also.
Yeah, I think, I mean, in my practice, if the person is, pretty neuropathic and he has such a severe displacement, I think from get-go, planning for a hand-foot fusion is not a bad idea. It saves them multiple surgical interventions. All right, let's move on.
Just a
Sorry,
one.
Dr. Chris, last
Like
question.
just
one
on the closing note, like when do we go for a primary fusion in with ankle fractures in diabetics, and like what would be the ideal post-op protocol, and like what is it like, and what are the ideal fixation constructs or implants that are to be used? Like, is there any consensus on number of pro-tibia screws that are to be used?
No,
And,
so Chinmaya, so the main thing is, you cannot club every diabetic in one pigeonhole, okay? Because it's a spectrum, and one end they will be diabetic, but they still have sensation. You see, in those cases, you could put multiple syndesmotic screws, but then the other end of the spectrum, you have some diabetic guys who have no sensation at all whatsoever. You can actually do the surgery without anesthesia. I have done nailing without anesthesia in diabetic patients. You see, so in those kind of scenarios, that's the difference. So it's a spectrum. One size doesn't fit all.
Yeah.
Kamal, you have hands up, and Rajesh, you have hands up before.
Yeah.
So, Dr. Chris, you said a nail right from knee, you go up to the talus or you go up to the calcaneum. If you're going up to the calcaneum, why are you not
No.
putting the hindfoot nail which you pass from the calcaneum, and you
That's
can
just-
hold the calcaneum
we don't.
talus better?
No, we don't go to the calcaneum. Your talus is very hard bone. Okay, so we put our distal screws in the talus, and that the purpose is then you reduce your fracture, you bring the fracture of length, and you keep your subtalar joints. And there's less risk of infection because far away the entrance pod is far away from the wounds, from the open fracture. So you go in from the knee. It's actually a technique written up by Alex Trumpeter in England in diabetic patients. And it gets rid of your external fixation of patients. Those patients can walk easily. You can mobilize them quite quickly because it's a very stable construct.
And so
Mechanically, no doubt, intramedullary constructs are much more stronger than extramedullary constructs. That much I can say.
is this the special type of nail, or do you use the routine?
No, just a
routine
routine
nails.
nail.
Going further
Just
down
a
into
routine nail. Yeah, in the calcaneus, because your calcaneus is very hard, and you make your fixation in the talus, and it's a quite stable construct. And you leave your subtalar joint free because that's sometimes they need to mobilize afterwards to get some mobility in the chopard. Because if you see the X-rays from the beginning, he doesn't have any arthritis of the chopard or not the subtalar joint, so he had some good mobility there. So if you keep that mobility, and he doesn't have any feeling, he has a quite severe neuropathy, and he has some. His blood vessels were calcified, so it's not good blood flow. So I think that's a way to even in an open fracture to solve quite a lot of problems.
Okay, I think we really need to wrap this up now and leave the last. Jagdish, have you got your presentation up now?
Yes, sir.
Perfect.
Sir, my screen is visible.
Not yet.
No.
Not yet.
Maybe I don't know. Indrajit, our IT
Yes, sir.
specialist,
He's
in-house
trying. I don't know.
specialist.
He says it's sharing, but it is not.
You can't actually
Some
email
security
it.
issue. He would have. Yeah,
So you
if he
can't
can email it to someone, and then we can do it. Jagdish, can you try again once? Can you log in from your phone or something?
Yes, sir. Yes, sir. Sir, I saved this presentation in my laptop. So just 1 minute. I will try again. Last time.
Yeah.
Okay.
So
There is an
We
option
can
of
continue.
sharing.
I mean, now that we have, while that's happening, we can continue our discussion because we don't have Jagdish's. But it is an interesting topic, though. Charcot neuroarthropathy. I mean, I must say we are all learning. I mean, I don't think we have answers for everything, and it's an interesting condition. I have been, dealing with Charcot neuroarthropathy for past 20 years, and my opinions on this have evolved over time. And again, everybody based on their experiences and the studies they follow and people they visit or mentor, get mentored, they come up with their own strategies. And it's interesting because everywhere you go, you have a slightly different approach. Like Chris, you mentioned going all the way up to only up to talus, and we have had great successes with the fusion of the hindfoot, and interestingly, these days people are talking about a flipper foot. Have you heard of that concept? Flipper foot, and I was skeptical about this flipper foot concept, but I'm on board now because if you talk about midfoot charcot, and we go down this road, I know Rajesh and we, talked about these things a lot because, the initial stages we used to just put one or two screws, small screws, and then we went down to bigger screws, and then charcot nail, and then a nail and a plate, and then so on and so forth. So we're just concentrating so much on the midfoot, and these patients, if you follow them long enough, they trash their midfoot, or they come back with a ulcer on the on the forefoot, and so on and so forth. And then the newer concept, then they can have problems in the. I need to get into OR, I think, because my next case is up. Then they break down their hindfoot, you see. So then people started thinking, okay, these patients keep coming back. Oh, so you're ready? Okay.
But the flipper foot you reserve for a very bad midfoot charcot, no? When it goes completely down and you fix the ankle, so the midfoot is flipping.
Yes.
You cannot do it for a first stage arthropathy. No, it's severe when the ankle is tilting. That's when you do the flipper.
I think I think Dr. Vinod, they're there. Professor Vinod?
Yes, I am here, but I may need to leave actually because my next case is on the
I
table.
think we'll manage if you are getting busy because we're just left with another 7-8 minutes. Thank you, Dr. Pajpavi, for your presence. For good
Thank
now.
you.
Thank you, Chris. Great to see you, Rajesh, Indrajit, and Aradhana.
So Dr. Chris will be with us for another 5-7 minutes more. And let us see whether is he coming up with the presentation or.
Sir, it is taking another minute. You guys can discuss still. I am fixing Jagdish's issue. There is some issue with this browser. I'm fixing it. You guys can continue the discussion till then. Another 2 minutes, I think.
So, Dr. Chris, kindly guide us on what's your take on situations which this patient came with. Would you have done right on day one, passing that nail from knee down to the talus?
Yeah.
And then would you also deal along with that, putting a plate on the fibula and fixing medial malleolus, or would you just not bother about other things?
Yeah, we have the very big diabetic unit, and we learned a lot with those patients when they have loss of sensation, 15 years old with bad followed diabetes. We don't bother anymore to do an osteosynthesis. We put a nail down or up, depending where refractory is and what you want to keep. We go for a primary hindfoot nail. If there is more involvement of the joint, we go for a primary nail through the knee if we feel that we can keep the subtalar joint. It depends on the status of the osteoarthritis around the chopard and the subtalar joint. But the only thing that we try to do is to bring length to the fracture, that the fracture can heal. After what you do, you bring your external fixators to the inside. And if you have any doubt about subtalar mobility, chopard joint, we do a hindfoot nail. If you feel that the patient can benefit from some subtalar movement, we go from the knee down. In this case, because of the medial open wounds, we probably should start immediately with a knee nail because you're far away when you pass your material, so you get less problems with. You can still deal with your medial soft tissues because I think it was an open fracture. If you see the primary picture, you saw that the medial malleus was sticking out of the skin.
Dr. Chris, I agree with your point of the subtalar joint. If it is pristine, leave it alone. But do you have any kind of study saying that this is more stable? One of the problems with sharp foot is evolving instability after fixation after few years. So do you have any
Yeah.
comparison between hindfoot stability, hindfoot nail versus the
There is-
tibial nail?
Yeah. There is a study about geriatric fractures and diabetes fractures by Nikos Koukoulias, who looked at it, and then Alex Trumpetier, his study about the knee nail. So there is some evidence stating that it's more stable, and the reason why is because your talus is a very hard bone, so you can do a fixation into your talus. The calcaneum, you cannot do it. The calcaneum is soft bone. Okay, so if you do, even if you do a hindfoot nail, if we do a hindfoot nail, we put some screw in the calcaneum, but we always will put a screw to the talus also, because that gives you the rotational stability of the implant because of you going into hard bone. And that's why probably if you go for a knee nail, it's even more stable than a hindfoot nail because of the bone itself, of the talus. And then the fracture heals around it, but you need to bring it in length, and you need to do the reduction. That's for sure. The length and the reduction, but you don't touch the fracture side.
All right. So I think we have
And those
Jagdish at
pieces
last. Yeah.
Ooh,
Sir, can you see my screen?
Yes.
Hello.
Yes, Jagdish, go ahead.
Go
Full
ahead. Go
screen.
ahead.
Okay. Sir, so without delay, I'm presenting a case of compound pentalar dislocation. So it's a 42-year-old male patient. He sustained trauma due to fall from height. He had a left side open wound on the medial aspect. The talus head was exposed and extruded. The wound
Jagdish,
was
please go
not
full
so
screen.
much.
Please click full screen.
Okay. Okay. Yes, sir.
Yeah.
So wound was not so much contaminated, and the distal neurovascular was normal. The SpO2 was found 100%, and he got also injury on the right side ankle, mild swelling. So this was the clinical picture. So we can see there is a around 20 by 10 centimeter wound over the medial aspect. The talus, as we can see clearly, and there was a 2 tendon, tibialis posterior, and maybe it was FDL, and there is some skin loss. So patient was went to the orthopedic surgeon in periphery. He did X-rays. On X-rays, we can see there was a very rarest enteromedial exclusion of the talus is totally dislocated from talonavicular joint and subtalar joint and tibiotalar joint. So we can see there is a flail foot, and most commonly we found is enterolaterally, and most commonly it's compound injury. So primary surgeon did CT angiography to rule out the vascular injury. So I did some zoom, and we can see there is some cheap avulsion fracture from the lateral malleolus, and we can see there is one bony fragment in the sinus tarsi. So talus was entirely intact, no any major fragment fracture, and there is CT angio was normal. And without delay, I shifted patient to the OT room, and I had so many options: debridement, X-fix, debridement reduction, and K-wire, closer, only slab, and MRI CT, and for further plan. The one another plan, total tolectomy and tibiocalcaneal fusion. And the last option was debridement, reduction, K-wire, and primary reduction of fracture and repair of the soft tissue. So what I did, I did reduction. It was got easily. I stabilized the joint with 2 K-wires of in subtalar joint and 1 K-wire in talonavicular joint, and completely reduced the joints. And what I see there is this tibialis posterior, and the deltoid ligament was ruptured completely, and it was most of the from the distal part. Some distal deltoid, distal part of the deltoid I have seen, and I took the chance, and the wound was not contaminated, so I repaired the deltoid with fiber wire, and it was completely repaired. And we can see there is a tibialis posterior, and there is a flexor retinaculum which was avulsed from the medial malleus soft tissue. So I repaired it also. So there was one bony fragment in sinus tarsi, and there are avulsion from the fibula. So I took an incision on the lateral side. This fragment, free fragment I removed, and there was a chip of the lateral process of the talus, which did not have any subchondral bone. So it reduced with the lost K-wire. And it was the avulsion from the fibula. It's like ATFL with AITFL, entire coverage. So I repaired it with a 2.8 titanium anchor with fiber wire, and I repaired it. So it was my after the closure, wound was completely closed, and this was my post-op X-ray. After 2.5 months, 6 weeks, I removed the K-wire from the joints, and non-weight bearing gradually start the mobilization. Wound healed completely. There was any sign of infection, and gradually mobilization and strengthening exercise was started. I keep patient non-weight bearing for 3.5 months, then start gradual mobilization. Contralateral side, I repair the medial malleus, and this is the movement after 7 months. What I got, and there was any sign of avascular necrosis. There was final follow-up, and there is some restriction of the inversion eversion movement, but he achieved good dorsiflexion and plantar flexion. So what the conclusion of this injury? It's severe, and it's very rare injury. There is a very high risk of complication, avascular necrosis, infection, and arthritis, and the urgent management is critical. We should urgently reduce it, stabilize it, wound care with IV antibiotic, and long-term rehabilitation. So, any comments
Very
from
nice.
sir?
Dr.
No, I
Chris?
think I would have done the same thing. If the wound is not contaminated, is a clean wound in a young guy, I think the most important thing is to reduce the talus immediately. That's the most important thing. And then reduce tissue damage. You have seen on the X-ray that you have a Wachstabber fragment. So your syndesmotic area was unstable, repairing the ATFL, and the ATFL stabilized also the lateral part. So I think it's actually the way to go. I would do the same. I wouldn't put an external fixation in this young guy, because I think if you can stabilize the talus, it's enough, and then you get mobility in your tibial talar joint. So actually, I don't have any remark. I mean, it's fantastically done, and I would have done the same thing.
Yeah.
Yes, sir.
I think very good, very well done, Jagdish. So I think the primary, your concluding remark is about do it primarily. And as Dr. Chris said, if it is not contaminated, I think we should go ahead and do complete and they get a. But one question is, why was such a long amount of immobilization? I would probably have been a little more aggressive for 3 months. I would not have waited because there's no bony problem as such.
Yes, sir. Sir, I just immobilized for only 6 weeks. After 6 weeks, I removed the K-wire and start mobilization. This weight bearing, I started lately because he had both limb injury. The contralateral side, he had lateral malleus fracture also. And
Makes sense.
so, yes, sir.
Okay.
So some I read studies. They said the total telectomy primarily is the answer to did it, because the chance of infection and complication are very high.
No.
I think we can always do a talectomy if we later on, but salvage of the primary. I mean, there's nothing like, if you could have done talectomy because your talus was already out. But now you know that you've salvaged and you've given the patient complete life better. So I think that's the way to go. Talectomy is for a crushed talus where you cannot salvage. Then you can think about talectomy. Today we can even do a 3D printed talar implant, replacement. So I think we've gone away much of talus. We always stripped. I mean, your talus was intact, completely intact. So there was no point of doing a talectomy at all.
Yeah, and I think the other is there some
sorry.
soft tissue which is giving back the circulation to the talus. So most likely the deltoid ligamentous vascular supply and maybe some part of intraosseous vascular supply was left intact. That's why this talus could survive the insert. Yeah,
and it was an anterior. It was an anterior luxation also, so probably the anterior part wasn't open. So you have also the anterior part that gives you your talar neck anyway, some blood flow. So I think it's a perfect way. And even if you have an open fraction 𝐒𝐴 with one part which is extruded, giving it a wash and putting it in again, it's what we advocate now and stabilize it. So I think there is no room in except for probably very bad contaminated wounds. Then there's probably room. But if it's feasible, do not do a talectomy from the first time. It's only salvage procedure, nothing in a primary stage.
Yes.
Yeah.
Thank you, Dr. Chris. I think we are now closing in because the time is running out. I thank Dr. Panchpavi, who is not right now with us, but he was here for most of the time. And I really appreciate and I really thank from core of my heart and from the IFAS Society. Dr. Chris, you made it for this particular Friday academic meeting, and we will keep bothering you for future meetings. Kindly do accept our invitation whenever we approach you. And we are extremely delighted to have this beautiful session. And once again, kudos to Jagdish, Aradhana, and Chinmaya for presenting really good cases, an eye-opener for most of us, and very, very learning points we carried back home. Thank you all. And
thank you, sir.
And good night.
Thank you for the invitation.
Thanks for joining us for this Friday academic. Thank you, Dr. Simon. Thank you very much.
Thank you, sir.
Okay.
Thank you.
Right.
Thank you.
Thank you.
Bye-bye. Bye-bye.